Oh my God, as I live and breathe.
Yes.
With
I
you.
will tell you, good to see you. This is a miracle, and I consider myself very old-fashioned, and I'm able to come on. So
Oh,
I'm very proud of myself.
if you know, every time I attempt a Facebook Live, it doesn't go well. See, now I don't have Laura. I wanted to get Laura Bowden on here with you because she's one of the Dow Corning people. She
Yes.
got sick from Dow Corning implants back in the 90s, so I wanted to get her on here with you. But okay, so we've got, now let me see if I can do, how do you do a watch party? Oh, more ways to go live. I was trying to put it on our Michigan page. All right. Well, I don't know how. I'm with you. I'm old fashioned and I don't know how to do any of this stuff anyway. So, all right. Well, I'll introduce you. This is Dr. Khan, and Dr. Khan is in Novi, Michigan. And I started a support page for people in Novi, or not people in Novi, people in Michigan, because I had breast implant illness and didn't know it for 20 years, and I didn't know it. And the only doctor, there was only one doctor, I believe, on the list of explant doctors on Nicole DeRuda's site when I joined her Facebook page. I think there was one. And I thought, I've been up a year and a half, and I thought, this is ridiculous that we only have one doctor. And then you found me, and I thought, who is this guy? Who's this Dr. Khan? And
See, I will tell you, I
once,
came out of hiding.
yes, and once I started talking to you, and because I was very suspicious, and once I started talking to you, I thought, oh my gosh, we not only have another explant doctor in Michigan, but we have somebody who has never put implants in, only to pass your boards to become board certified, and has never believed that implants were safe. And you've got like almost 500 explants under your belt, which is a lot. That's a lot. And you do it
Yes.
nice and slow, how I think people should, and you cut a big enough incision. And so I wanted you to answer questions for women and tell people what you want, what you feel they should know about breast explant surgery and breast implant illness.
Sure. No, I will tell you, I just did three today. I literally just a matter of like literally 10 minutes ago, I finished my third case, and I only do three of these a day because I book them for 4 hours. My first patient, a very interesting patient, and again, just from today, earlier today, she comes in from almost 4 hours from the the Pacific coast. And so she, in 2017, she has had since 2006 saline implants um, uh, under the muscle. In 2017, after 11 years, the one on the right spontaneously ruptures. And as we know from the saline implants, when they do rupture, it's like a water balloon. Automatically, the chest and you have a flat chest
Calcium.
because because of the saline gets absorbed by the body. She sought consultation from a plastic surgeon in San Diego, board surgeon, and believe it or not, the ultimate and the determination was at the end of the consultation, because now there is asymmetry. The right side is relatively flat chested, and the left there is that saline implant. Lo and behold, believe it or not, Tracy, and everyone who's watching, the decision was that the surgeon was going to take a needle and deliberately, purposefully rupture the implant on the left side so that the patient would now have symmetric chest so that she could go about. And from since 2017 till today, this morning, she flew in, she felt uncomfortable. Excuse me, these are the sensor lights, and so they're going to turn back on right now. So she basically came in, and her biggest worry was, I want to make sure that the capsule needs to be removed in its entirety. Otherwise, you're going to leave that burden behind, and what's going to end up happening is the patient will recover, bounce back maybe 50-70%, and there will be continued residual inflammation and the trigger, and the patient would not bounce back nicely. Now, one thing I want to say, and this is the gist of the conversation, you have to remove the capsule and the implant and walk. the second case and the third case, and you have to do it very meticulously, very carefully off of the chest wall, and 95% or so of the implants are right on top of the chest wall underneath the pectoralis, so that the dissection underneath the pectoralis is as important and critical because you don't want to damage that muscle. This is the muscle that you use to lift up a gallon of paint, for example, and you're using that to basically also add volume to the chest, and let alone all the day-to-day activities. Now, I always want to stress 5 things that your surgeon must do is to confirm and to have proof that your surgeon, now these are the patients who are seeking consultation outside of the US, within the United States, and going to these explant specialists who are especially on the Nicole site. You have to look at 5 things. Number one, you have to make sure that the incision is big. You cannot do an explant and block from a 2 or 3 centimeter incision. That's virtually impossible because that implant has volume, has a size. You cannot squeeze it through a 2 or 3 or 4 or 5 centimeter incision. So number one, your incision has to be 10, 11 centimeters. And if you can imagine that the implant and the capsule sitting on the table and block, what size, what's the diameter of the capsule and the implant that would take for you to remove it. So the size is important. The incision length is very important to look at. Number two, you also want to make sure that the pictures are there, because the pictures with the patient's initials, the date, so that with the digital cameras you can see that the implant was removed truly. Now, I will tell you 100% of the time it's not possible, but the purpose, and there should be an intent and a deliberate mental preparation for the surgery. You cannot. So within Michigan, unfortunately, there is a surgeon who proves or claims to be an explant specialist end block, and what that surgeon is doing an end block along with the lift in 3 hours. And I'll tell you, that's virtually impossible, unheard of. That's just like saying, from Michigan, I'm going to fly from Detroit to San Francisco in 2 hours. You cannot do that, and virtually impossible. The lift alone in itself takes 3 hours or so to do. The end block in itself almost always takes at least 3 hours. So the very important point is you have to see the pictures. And number three, you have to make sure that the timing is also very important, because if it's done in 2 hours, I can assure you it was not done right. So my last one for the day that I just did, my third explant, this was a very hard capsule, which makes my job easy because the dissection is relatively easy, versus a very thin capsule. The dissection is more meticulous because the dissection has to be done even more smooth. And so I say the higher the capsular contracture, the easier the dissection for me. Obviously worse for the patient because she's having signs, symptoms of that tightness on the chest. Number four, you have to get the implant from the chest, and basically when you remove it and block with the capsule on it, basically sending the capsule off, because remember it's very hard tissue, but also giving the implant back to the patient. So many patients, say, well, the hospital does not allow, and I'll tell you this, there are committees for every hospital, and they say, well, it's not safe to give an implant back to the patient. And I'll tell you, guess what? It was on the patient's chest. Are you telling me you cannot hold the capsule in your hand or in a glove or basically a Ziploc sealable container? We do this all the time with what we call pathology bags, where you have, it's a sealed container, be it a jar. Absolutely,
Yeah, it's a biohazard. They give it back.
yeah, you can.
Biohazard.
Right. No, right. So exactly. So I will tell you, if you can, when we pick up debris with our hands, for example, we get it on our hands, but we can wash it off. That's the keratin on the epithelium of the skin. So you're not going to be in any danger. Now, if this implant, for example, God forbid, has mold, which is rare, then you can say, but guess what? It's still in a sealed container. It's not that you're handling it with your hands. And I will tell you, in a biohazard bag or a container or one of those formalin containers, you can certainly give the implant back. And I will tell you, I tell this to all the patients, the hospital doesn't decide. The hospital is actually, you as a surgeon or the team leader, you're overriding anesthesia. Anything, any problem, any issues, the surgeon is responsible. And I say this to everyone, we can certainly present this to the committee and say, you know what, it is very important for my patients to get the implants, because if you get a ruptured saline implant, you know that this dissection was not done right, or this was the 2 or 3 centimeter hole through which the implant was removed after it was punctured in the chest. And I will tell you, when I was in training, and this is what we see all along, all over the US, if you go to any plastic surgeon, you will see that almost always, inevitably, vast majority of the patients, the saline implant is deliberately ruptured and it is removed from a 2 or 3 centimeter hole, because we don't want to make a big incision on the chest.
Yeah.
So very important, yeah. And the last thing I always want to say is, the ultimate proof, I told Nicole, I called her up, very nice lady. She's done a lot of good for millions of people. There's almost 90,000 patients. So you can imagine each one of them has a friend, has a family member, and each one of those lives are affected by the person who has the breast implants. And I say this, that we have an obligation to say, you know what, let's come up with a list of docs who are only explanting, because you know what, these folks believe in breast implant illness wholeheartedly. Now, I will tell you this, if I believed in breast implant illness 99%, I promise you I would have put in an implant, because why not? And this is you have to believe in it from your heart. And I say this to you, if I believe in a cause, I'm going to fight from it from my heart. I'm going to be up late till 2 in the morning trying to figure it out, trying to do, yeah. And you fight it, and you have a just cause. I use an example I tell my patients when they come into consultation. Well, if you were sent to the Vietnam War and you did not believe in it, what would you do? You would be in the source. Always inevitably.
Hold on.
Yeah.
I'm
Yep.
trying to
And
get
so
you
you,
on watch party. Go ahead.
yeah, yeah. So what happens next is, before you make the decision to go to the operating room, you're fixated. You're 100% basically determined, and from your heart and your soul, you're going to try your utmost best to going about and removing the capsule, because that's what the whole thing is about. And I will tell you, if you go to a surgeon who believes in breast implant illness, so for example, if I were a patient and if I were to seek out consultation, I will tell you I would seek out the expertise of Dr. Chan, for example, because I know he's only taking him out, or Dr. Feng, for example, or Dr. Barr, because they have come out openly and said we don't insert implants. And I'll tell you this, there's less than 5 surgeons that I know in the entire US that are not putting in implants. If we can get 10 more, 15 more, 25 more, and we start publishing data, and this is what I told Nicole, that to come up with a list of docs who are only explanting, I promise you the world will be a different place, and the breast implant illness will be much more recognized. And we're starting to see the change, because guess what, 2, 3 weeks ago, and I mentioned this when I was on the Facebook with Darby, that there were 2 surgeons. One was an OBGYN, one was another rheumatologist, who told the patient, please go and get your implants out. And I will tell you, that's a big change, where now the primary care doctors are now jumping in, or the subspecialists like rheumatologists. And now they're saying, you got breast implant illness. And hopefully we can have, I asked one of my colleagues who is a medical oncologist at Beaumont Royal Oak, get me a grand rounds, I'll give a lecture on breast implant illness. It is truly a breast implant illness, ALCL, anaplastic large. I'm going to give a grand rounds to 300 physicians, and let me teach, because that's going to be very applicable, and I will teach them what I know as a plastic surgeon. So the more we talk, and the more Facebook chats that we have very similar to this on a day-to-day basis, hour by hour, and if Nicole is listening, and hopefully she told me she would, come up with a list of docs who are only explanting. I promise you, we will get the rest of the docs more informed. From what I understand, Dr. Feng was present at the ASPS Society meeting last month, and she presented her data. That is fantastic news, because what we're doing is we're getting clinical research done, we're getting more information, more data, so that we can make this world a better and healthier place, period. Now,
Yeah.
Tracy, having said that, please ask me any questions.
I'm trying. I'm trying to get us on a watch party. I was trying to I pulled up a bunch of questions that off of Nicole's site that women wanted to ask, like, are you women should be asking their surgeons, are you board certified? You're double board certified, correct?
Right, right. Now I'll tell you, so that's a very heavy question. Now there's only one board, which is the ASPS, American Society of Plastic Surgery. Now guess what? Right now I could make up a board, American Society of Aesthetic Plastic Surgeons of North America. Tracy, I can make you a member, and I'm having myself be a board certified. Guess what? Right here in town in Michigan, and I want each and every single one who's listening, there's an ENT surgeon who claims to be board certified in plastic surgery. Absolutely not. This is basically a cover up. That patient is, whenever you go into ENT training, it says ear, nose, throat. It doesn't say BENT, breast, ear, nose, throat. So that doc, by the way, is putting in implants more so than anyone else. And it's a shame, and it is a disgrace, and I say this very openly, for Lansing to allow someone who did on-the-job training to go about putting in these implants who's not truly board certified by the real board. American Board of Cosmetic Surgery is a garbage board. They have nothing to do. All what these folks are doing is they get a certification, they pay their dues, and they're not board certified plastic surgeons. And I say this very, very boldly. There is an emergency room doc in town, part of a spa, who's putting in implants, and what a shame that no one's looking at him and asking him. There's a surgeon in town, very popular up in the Birmingham area in Michigan, who's putting in implants. He has no formal training in plastic surgery, so it has to be a board certification. And what I mean by board certification is, I'm actually going to reach forward, and I say this to everyone. See this logo right here, which is that O sign with the American Society, that O sign, that is what you need to see, that the patients need to see in order to be board certified, because this board certification means nothing. Now, another important question to ask is, what do you openly believe and declare you believe in breast implant illness? Because that's very important to mention, because many surgeons don't want to scare off the other 9 patients who are waiting in the pre-op or in their consultation area, that might get scared by the other lady who's coming in with breast implant illness. Because it's, you should not, if you believe in breast implant illness, you should not be putting in implants. And I will tell you, and as we all know who is listening, breast implant illness is very real. It is 100% real. It is only going to be recognized as an entity. Look at the hundreds and thousands of women who have come forward, who have dramatically improved as a result, their anxiety, stress, depression, amongst many other problems. Going back to your question, board certification is ASPS board certification. This is the board that authenticates and verifies the training is concrete, crisp, that you do things right. It keeps an eye on the docs, making sure that there is professional, ethical behavior, that the operating rooms that these docs operate in, that's the first question they ask. Are you operating in a certified facility or not? Because many of the surgeons that we know right here in town in Michigan, they're operating in a room that they make what would be a procedure room and claim to be an operating room. There are many liposuctions done right here in town in Detroit who are gastroenterologists and are doing liposuction on the abdomen, and they're advertising openly on their website. Gastroenterologist is a GI doc who does scopes, EGD, and colonoscopies. They're doing liposuction under local. Board certification is a big deal. It requires that right training, that right expertise, and the docs are not cutting corners, and it's very hard to become board certified.
Okay, so you're board certified as a MD?
Yes. So MD is a medical doctor. This is the allopathic medical school. This is the highest level of training. Now, there are docs that they are DOs, for example. Now, these are doctors of osteopathic medicine. My board does not recognize them. If I go to their hospital, my continuing medical education will not be recognized. My training is different. My education, my scores, my level of sophistication. And this is where you go across the country. The MDs are very different. And I use the word very different compared to the DOs. And Tracy, I will request each and every one of us, our listeners, to say and look into what's the difference between an MD and a DO, because these are two different trainings, two different thoughts, and one is not the same as the other, period. That's just like saying, well, a chiropractor is a doctor. Well, I will tell you, he cannot operate. Now, the DOs can, but their level of training expertise is very different. And this is true from the very beginning, from the time they take their MCAT, the scores, their GPAs, the way they get accepted into their respective training programs. So a very different standard of care, to the point where I will tell you they cannot become board certified by the ASPS, the American Society of Plastic Surgery, and claim to be a part. They can make their own board, but this is something that the patients need to look into and determine. You can go and seek consultation from, or talk to a friend as to ask what's the difference between an MD and a DO.
Okay, another thing is you operate out of a surgical suite, your own surgical suite. Some
Yes.
feel concern over that because they'd feel safer in a hospital setting, which I disagree, because I think there's so many more germs in a hospital. Like, as soon as you walk in, it's just germs. No matter what they do, you're walking into germs. So I would prefer a surgical suite because I think there's way less germs. And so can you explain your surgical suite and all the credentials that come along with having a state-of-the-art surgical suite? And you're only, what, 300 feet from the hospital, correct?
Correct.
Providence and Novi, right?
Providence Park. So that's a very good question. So it's very important for the surgeons to operate in what they call a quad SF, which is a certified, the highest and the gold standard of a surgical operating room facility, where the ventilation system, the hygiene, where the team from the organization comes in and evaluates how many cases, how many infections, what complications. Now, you cannot do a lady that comes in with a pacemaker over at the surgical suite. You have to go to the main hospital. This is across the country, the standard of care. A lady comes in who is in her 80s, for example, has multiple problems, medical issues. You have to do these cases at the main hospital per standard of care. Now, as we move forward from the 2010, 2020, 2030, there are a lot of surgical centers that are opening up in order to contain the costs, because the hospital in itself, their level of billing, many of the outpatient surgical centers, this is across the country, done very safely. This type of surgery can absolutely be done very safely because this is outpatient surgery. Now, if a patient comes in, is on basically multiple medical issues, has lung issues, is, yes, absolutely, you have to go to the hospital because you may want to have them recover overnight in a 23-hour obs, for example, or there might be an issue, whatever it may be. But breast explantation across the country is an outpatient procedure that can very safely and very nicely be done in a surgical suite that is a certified, aesthetic, and clean operating facility, where you have the same equipment like you do. And like you said, it's cleaner, more uh, efficient as far as, and certainly much less costly. The moment you walk into the hospital, you're basically paying the costs of utilizing the operating room, pending how many hours that you're there.
Right. I had mine done in Costa Rica, and several people, several women, if their surgery went over, they ended up paying more for their anesthesiologist and hospital time because we were in a hospital. But can you explain? You don't believe in doing a lift at the same time as en bloc. I had a lift at the same time. I had a reduction in lift, and I do wonder, like, if I could have gone without a lift. I really thought I needed a lift, and so I went for the lift. And you don't believe in doing lifts because of the dangers. And once I sat and listened to you explain about the dangers of doing a lift, I probably would have waited. And
Sure, sure.
I,
And see, look at you, Tracy. You are going around talking to a lot of women. much more than I am because I am seeing whoever is coming into my office, but you're talking to them via groups and over the so many years. See, the goal of the operation on the day of the surgery is what? Very simple. Number one,
Life.
yeah, remove the implant plus the capsule and block.
Yeah.
That in itself, 4 hours. Guess what? The tissue is inflamed. It's angry. There is a lot of, it's not healthy tissue. And there might be a rash. There might be other issues going on. The dissection is pretty intense right off of the chest wall, underneath the breast tissue, the pectoralis. Sometimes you have to cut through the pectoralis. At the same time, you add 2 or 3 more hours for a lift. Guess what? The patient's on the OR table for 7 hours and you lead to problems. And guess what? On the last time when you were here, I showed you the pictures of the ladies where they would, and they did extremely well without the lift
Yeah.
because they, and so why burden the chest, potential for clots in the legs, breathing problems, complications, infections? And they say if you're on the OR table for more than 6 hours, it has been shown from the thousands and thousands of operations that they have studied that the risk of infection, no matter what you do and you follow the protocol, just the fact that you're on the OR table for 6 hours or more, your chance of infection problems, complications, breathing problems, pneumonias, lung problems, DVT, clots, whatnot else go up exponentially. So why take that risk? And so I say, guess what? Many of the patients don't even need a lift.
Right.
And I say, yeah, so I say, get the surgery done, which is the end block resection, let it settle. Then the next time, or maybe you might not need the lift, and then come around maybe a year later or two, and then do a lift, which will have a better predictable outcome. There are some ladies that have come who got the lift at the same time, and when the tissue retracted and regressed, they recoiled. Guess what? The nipple was pointing up, a very difficult problem to fix.
Yeah. There's a gal who went to the same doctor as me, who I think this week is getting a revision because her nipples ended up too high from the lift. So
Right.
exact same
Mm.
doctor. And he's one of the best end block doctors, out there. There's a handful of you guys and he's one of them, and she ended up too high. So once I listened to you explain that, and I just heard of another woman who had nipple death, who lost her nipple from, and I didn't do my research first. I should have done my research, but I didn't. If I had, and if I had talked to you first, I probably would not have done a lift at the same time.
Right.
I think you're right.
And
A lot of
mm,
trauma, but I mean, there's a lot of doctors doing it. So, it's
sure.
just wherever you're comfortable, but yeah, that,
So, sure, I'm going to mention a few things. Many of the surgeries that I see, the other explant surgeons, and I'll tell you, and I say this very boldly, we know, and I say this to Nicole and to you and to all the ladies who are listening, and hopefully we can pass this on. The explant list by Nicole is certainly a good start.
mhm,
But, and like Nicole mentions on her website, it is not the final certified answer that you're going to be guaranteed an end block by the
right.
surgeon, because that is not true, period.
Oh,
There are a lot of patients, yeah, there are a lot of patients that I myself have seen who've been explanted by those surgeons who have come and the following year had the mammogram done or an ultrasound which shows residual capsule. The doc says, well, I didn't want to hurt you, and 10%, 25% of the capsule remains behind because there was no deliberate, determined intent to remove the capsule and block, period.
yeah,
And so, and I will tell you, and you have to be very careful with that, because the last thing you want to do is to do a second operation, or worse, to recover 80% or 70% because you got the residual capsule remaining behind.
right. Yeah. Um, we just had, there was the show, The Doctors. If people can look back a couple weeks ago, a show, The Doctors, and they had a bunch of ladies that were at the FDA hearings in DC with me. And Angie Everhart, is that her name? She's some famous model or something. Anyway, she was on and she had implants, and she had a doctor in Hollywood remove her implants, but he left the capsule behind, which, this is what I keep trying to stress to people, the how important it is to pull these out en bloc. And en bloc means the scar tissue that's wrapped around your implants has to all come out because it's all toxic. It's all been contaminated. and he left it. He probably punctured them and pulled that implant out, the saline implant, and drained it and pulled it out and left the capsules behind. Everyone else on the stage that had them removed en bloc were fine. They recovered and they were doing fine. She had hers removed and she was still deathly sick. And at the very end of the show, she said, I'm going to the doctor. I think she went to Dr. Rankin down in Florida, and he removed all the extra capsule that we are told will absorb. Your body will reabsorb it. We're just going to leave the capsule behind and you will reabsorb that capsule. And that's not true. And that
Not true.
proved it, absolutely proved it on that show. And now I believe Dr. Rankin just went in this week or last week and removed all the extra capsule. And now we get to see if she recovers. Because that,
No, that
so
right, and so this is a very important point. And if I'll say this, if there's nothing that anyone got, but what you mentioned, this is the gist of this whole talk. Now, I just saw a question from Holly Davis. Does Dr. Khan do fat transfer? Now, let's talk about fat transfer. Fat transfer to the face, very common, very, very trendy in just last 10 years, very commonly done. Very nice, effectively, it adds volume to the face. On the face, where you have a robust blood supply, you have almost 30-40% of the fat dying in the best of the hands by the Coleman technique and by the new techniques that have been developed. Now, just imagine you take that fat and you put it on an area where you have just done an en bloc. If 30-40% is going to die on the face, can you only imagine 60%, if I were to just throw an example? Because you have to have blood supply. And if that fat dies, guess what's going to happen? Fatty necrosis. And next year, let's say if you get a mammogram, it's going to show up as those hardened calcifications and unnecessary biopsies. Absolutely, I will never do it. I've never attempted it. It does not clinically, theoretically make sense. And I will suggest that this is not even an option.
right.
The only one option that I will say is what they call the deep inferior epigastric artery flap, which is basically they take the fatty tissue minus, you don't touch the muscle, which is in the old days used to be the tram flap, where you would do the transverse rectus abdominis muscle flap. You don't want to hurt the abdominis muscle on the belly because now you could get a hernia amongst not being able to lift. So you could attempt to go to a microsurgeon and do that 6, 8, 10, 12, 14, 18-hour long fat transfer where they take the fat and then microsurgically connect it onto the chest artery so that that whole area takes, and this is your own native fat tissue. Even in the best of the hands, the fat can die, and then let alone next year, remember, you likely would have had a mastectomy, or if you add to the initial native breast, if there is fatty necrosis, there might be some concerns or questions about what this fatty necrosis and the hardened area of the breast tissue is. And this is something that is a huge undertaking, meaning but normally done where you have the native tissue and in the good hands, in the hands of a microsurgeon who does these on a daily basis routinely, likely at a university setting. This is one practical, viable option, but it comes with its own set of problems.
Mm-hmm. I have somebody here asking, so you do not accept her work with insurance. You are in her network.
So I will tell you the unfortunate reality is I want you to look at the CPT codes and how much the insurance reimburses these days. Now, I am 100% for the fact that the insurance companies, along with the manufacturers, both come in and offer the patients the relief that they need. Now, look at me. The whole day I've been operating, and I use numbers just so that you understand. I have had a crew, anesthesia, the equipment, just alone opening the operating room, the certified ambulatory surgical center. To maintain that is a big headache. When I use the word headache, meaning you have to keep up just like you do with any facility, whatever it may be, so that you have the standard of care that's maintained, which is what everyone's trying to avoid because that's an added cost. To have registered nurses, to have the equipment, and excuse me, sorry, the sensors are on again. So all of that, and it's, to do it right, has the, sorry, all of that is a cost that is ultimately added on. Now, if you look at 12 hours of running an operating room with 5 people that are there, you can only imagine what the costs are. Now, if you look at what the insurances are, now let's look at and dissect, because I have to say this is an important question too. Do you know how much the insurance is? And I want someone who's out there who's a biller or who can look up removal of implant and prosthetic implant from the chest. The reimbursement is $600, $800. I say this to all the patients who are listening to look at where we are with Medicare, for example. My friend, he's a gastroenterologist. He did a colonoscopy on a patient. Do you know, as a professional fee minus any biopsies, just a screening colonoscopy, do you know how much the Medicare reimbursed him? $205.76. Now, this is reality. Now, I'm going on live. I'm telling you, this is the number. Now, I want someone to correct me and say it. No, this is the professional fee. Someone does a knee scope or a knee replacement. See, now the days of insurances are gone, meaning the insurances, they don't care, they never cared, and they never will care. That's the harsh reality. You do a face laceration as a plastic surgeon, on average, $250, $350. Before, in the past, they used to pay a lot. Breast reduction, for example. In the 80s and 90s, you know how much the breast reduction would pay? $3,800, $4,200, which is now $1,200 if you're lucky. And that's a high number. A peniculectomy, not an abdominal plastic peniculectomy, $1,200. Now, these are dangerous operations, meaning involved operations. So right now, what has happened and what's the trend? Primary care doctors getting $40, $50, $60 per visit, $70. And you cannot sustain a private practice from insurance. That's flat out 100% accepted. So I say this to the world and to you and to every listener. If any person who's in internal medicine and family medicine who's playing by the book, you cannot sustain your private practice, period. You have to be thinking of, quote, clever, unprofessional, illegal ways to sustain your practice. And you know what I'm talking about, Tracy. You and I have talked about it before. You're trying to rush it. You're getting a PA to be seeing all your patients while you're just operating. Now, there's so many clinics that you walk into, the medical assistant is seeing patients and they run it by the attending, who's probably not even there, who's probably doing procedures. They're building up volume. They're having physician assistants. They walk in and out in 3 minutes. And you know what I'm talking about. So essentially, it is a non-sustainable practice if you go through insurance just because of what they pay. And I will tell you, no one is going to do en bloc and do the procedure unless they're doing something that is going to maximize on the volume and going to maximize, or doing shortcuts, which is wrong, because you have to spend the time, the due diligence, the 4 hours or so that I book every patient. Now, there are some docs who are claiming to do en blocs in 2 hours or in 3 hours doing an en bloc and a lift. 100%, 100%, you know this, I know this, they're not doing the en bloc. And the point is, you cannot go through insurance.
Yeah.
Yeah. I have a lady that's coming in next month, and hopefully she's listening. She has breast cancer. She's coming from New Mexico. So she has breast cancer. The whole surgery is covered by the insurance because she has breast cancer. She was given the option, you fly out here, she's in my network, we're going to do it at the hospital. Anesthesia is provided by the hospital. The staff, nursing, all equipment is brought in by the hospital. When we did the math, I was going to get paid $1,800 for the 4.5, 5 hours, which is, again, recipe for bankruptcy, because you cannot sustain a practice. And I say this to you, and I say this, yeah.
The amount of time and work you doctors have to do to remove these implants, it's
Right. And so, right. So I will say, and I told the patient, I'm not going to quick, and see, this is why if you go to any of these other docs who are RVU or insurance based, they're like, oh, I'll take it out in half an hour, 1 hour. I can justify that, doing,
Yeah, right.
and that's why. So I say to myself, I'm never going to do it because the patient is coming to me because of the whole commitment of the end block.
Yeah.
And yeah, and so the last one that I did, for example, at the hospital, and Tracy, when you were there on the June 18th seminar that I gave, the nice 68-year-old lady who had breast cancer, I spent almost 5 hours. Very interesting patient, and this is the one we discussed. She has saline implant on one side. Guess what? Silicone on the other. On one side, she has one below the muscle, and the other side above the muscle, done by what you call the pseudoplastic surgeons who do not know what they're doing, unfortunately. And I will tell you, I spent 5 hours, and it was the lady had an abscess too. That's why she came to me after the length of time in order to get these. So the bottom line here is this: to answer the question, insurance does not pay, they don't care. Even patients, for example, as a plastic surgeon, patients come in with massive weight loss. They have the pannus, the skin hanging down to the mid thigh. 7 out of 10 times, the insurance says no to these patients who meet criteria. And even when you do a penniculectomy, they end up paying $900, $1,200 depending on the plan. And guess what? Nowadays, the deductibles are 5, 7, 10, 12,000, and they throw the burden back to the patient.
Yeah. Yeah, I think that's our next thing is the insurance. First was getting them to call the FDA to acknowledge it as an illness. And then today they just released that. What did they release today? Um, oh, now I blanked out. But I think once we can get it down as an illness, insurance will have to, they're going to have to. But you know how insurance works. They'll just tell us insurance,
Right.
insurance isn't going to buckle. We'll move on. We'll move on to drains. I have so many women. I did not have drains, and I had a reduction and a lift and en bloc, and I did not have any drains, thank God. Um, but then there's other women who say, I would never have this type of surgery without drains. And I think, well, I had an even bigger surgery. I had the reduction and a lift and didn't have drains, and I had no issues. I followed all his instructions. I kept it really tight, the compression, and drains seem to be one of our biggest hot topics. So if you can explain drains to people, because you don't prefer to use drains because of various reasons I'll let you explain. And it frustrates me when I see women say, oh, he won't use drains, so I won't use him, or they only use drains, so I don't want to use them either. So I'm going to let you explain
So
drains.
So
Your opinion.
drains, yeah. So drains are very important when you have a lot of inflammatory tissue, a lot of what you call VP tissue, serosanguinous discharge, and a lot of area that needs to be dissected. Because you don't want that fluid to fill up in the chest wall in front of it and build up as a seroma, and that eventually needs to be drained.
Okay.
Now, a drain will not prevent a hematoma, which means is a collection of blood. Because remember, as soon as it bleeds, it coagulates like jello. It will never drain out of the drain suction catheter. You'd have to go back to the operating room in order to clear and remove the hematoma. So the drains are a way of collecting that excess inflammatory tissue that would inevitably form because it's a ruptured implant, or there is an abscess, or there's extensive dissection. But if the dissection is done right in the right plane, and as you will see on my YouTube videos, and you're in the avascular plane where you're very carefully taking your time and dissecting off, the amount of trauma to the tissue, the muscle, is so insignificant that there's no requirement for a drain. And I'll be happy to state that well over 90% of my patients, I don't put a drain, and there's never been a need, and I have not drained a seroma. Now, conversely, If I'm ever sitting on the fence and say, you know what, do I need a drain or not? I'll put a drain in because I can always remove it in 2 days.
You're right.
Number three, putting a drain is a dangerous deal because if you put in a drain and let's say if the patient pulls it out a little bit and pushes it back in, the bacteria gets introduced, or if the suction
Oh,
catheter opens up and you reintroduce the fluid back in, remember it's in that in itself is a potential catastrophe
yeah.
waiting to happen. Now, the drains themselves function. Now, I saw a lady last week, she has 750 cc implant and she is thin as a rake. And there's a lot of dissection that I'm going to do normally twice of what the 350, 325 implants that the patients have, correct? Now, guess what? The dissection is twice as much. And I'm going to go ahead and put in the drain because I know there's going to be a lot of inflammation around the dissection. Or if it's a ruptured implant, like I had a lady that came in with a 33-year-old implant, Dow Corning from the 80s,
Oh, wow.
a lot of inflammatory tissue. 100% of the patients getting a drain. Now, just yesterday, I heard from a patient, a doc here in town, who's supposed to be an explant specialist, putting in drains for 2 weeks, regardless on all and each and every single patient. I have to say that is, in my eyes, from my experience, unimaginably wrong. Because this is now how it is practiced. This is how you would say what and where, even after an abdominoplasty, extensive surgery from the xiphoid, from the upper chest to the lower abdomen, the
Oh,
drains stay 3 to 5 days.
well,
Oh, I see your nice cat. Yeah. Yeah.
hello.
Yeah. Yep. That was a nice introduction there. Okay.
Let me put her in the room.
Yeah. So after so and even an abdominoplasty, I did an abdominoplasty last Thursday. Guess what? I took a drain out today, and for the last 2 days, so I did an abdominoplasty last Thursday. I took out the drain today, and you could see the output was 20, 20, 25. And normally, just the drain in itself, having the foreign body inside, the body will put out on the dependent part of the body. So I took the drain out after 5 days, but to have it done in the system for 2 weeks, I will tell you it is dangerous, it is wrong, and I question the surgeon, their experience, their training, their intellect, as far as what's the indication and why put the patient out. And another thing that I heard when you were here last, Tracy, was the fact that the husbands are pulling out the drains or the medical assistants are pulling out the drains. Absolutely wrong. To remove a drain, it requires a lot of decision making. To strip a drain, maybe if there's a clot, to see if the drain was positioned well. You don't want to reintroduce this. I find at other facilities and this is very important for the women to understand. You cannot have a medical assistant remove drains or even a physician assistant, because it is a surgeon who makes the decision, because he's the one who put it in. And you cannot, it has to have a higher level of thinking and a sophistication as to, you don't want to take one out with the potential where it was not working correctly, because there was a reason for it to have been put in.
Okay.
If that makes sense. So to answer your question, drains are important to remove that excess weepy fluid. Majority of the times, especially the explant surgery, if done right, there is no indication for a drain unless required.
Can you explain what a capsular contracture is?
So very good question. So when there is a foreign body, so the implant that goes into the chest, you start forming a capsule. The body recognizes it as foreign. Now, you're going to form a capsule around a pacemaker on the left upper chest area, around an artificial knee, around the lap band port, for example, in the belly. Body or screws that someone has, because the body walls it off. It recognizes it as foreign, especially silicone. Now, this is the body's own way of reacting to the silicone. Now, if you look at the classification in plastic surgery, there are 4 different types of capsular contracture. Class 1, which is the mildest, normal, where you have a normal looking breast. The fourth one is the most involved, which is the one that I just did. So the patient has pain at rest just while sitting down. And number two, it deforms the implant and contracts like scar tissue such that it presses hard onto the capsule and distorts it on the chest. So you could look at a picture of a patient and see the implant that's riding up and really tight and hard, and just asking the patient, do you have pain at rest? And she says yes. By definition, you have that patient who has grade 4 capsular contracture, which means it's rock hard solid. You touch it and it would be like you're touching or tapping on the table, and it's very tender and inflamed and angry tissue. And this is the last case that I just did, which makes my dissection easy because the capsule is thick. Grade 3 capsular contracture is where you have distortion of the chest wall, but no pain. This is the scar tissue, the capsule that forms and distorts the implant itself. It becomes so hard because it's scarring and trying to wall and protect it off. Now, once, and see, this is very important to note, once you form capsular contracture, what happens? If I were to take the patient to 100 different plastic surgeons, board certified, you know what's going to happen inevitably, Tracy? The surgeon will remove this implant, score the capsule, which means open up that scar tissue, and inevitably put in another implant. And I say if you form a capsular contracture once, you're very highly, almost always going to form a capsular contracture. It's only a matter of time because you formed it once. If plan A is to form a capsular contracture, plan B is also going to be that, and it should not be the same as putting in an implant because the body is telling you, I don't like the implant and I'm walling it off.
So is it pretty much a guarantee, like these women, we're not told, most of us are not told at least, that when we get them, I was told I'd be put in my grave and my boobs would look great and I'd be 90 and they were lifetime devices. That's not true. So they should be replaced like every 10 years. So are you saying if a woman who gets capsular contracture once, she's probably more than likely going to get it with every set of implants she gets over the years?
Yes, yes, she is much higher at risk. And I will say this to you, vast majority of them, it's only a matter of time before they get a capsular contracture, and in a very fast pace, faster than the first one.
So I'll tell you, I'm very torn, like, because I'm not allergic to peanut butter. And so, like, my son's elementary school, we couldn't send peanut butter in or anything with peanuts because there was one child in the school who was allergic to peanut butter. So I'm on the fence here because I have friends, probably 3 of them, who still have breast implants and they don't appear to be getting sick. Although I think personally, implants, my opinion, are ticking time bombs, and you are slowly ruining your immune system and causing all kinds of other issues. So though my friends are not getting sick right now, I still think that they're damaging their immune system and they're doing damage to their bodies. But until I can prove that, then I am on the fence right now of, like, do you ban implants? I believe the textured did need to be banned. I had those for 12 years, and those are the ones causing that they have linked to the man-made cancer. But so what are your thoughts on explants? You have always thought since the very beginning of your medical training that implants were dangerous, and so you don't think that they should be on the market at all?
So this is my take, and this is my
Because I'm with you. Until I see my friends go down for the count, it's kind of like peanut butter to me.
no. So and I want everyone to understand what my thought process is.
Yeah.
My like where and like one husband asked me last week, so why? And I say this to you. In 2003, I was in surgical intern at Yale. One of my professors, his wives ended up getting breast cancer. And I, very nice, very approachable, big shot, very nice, very world-renowned surgical oncologist. And I was like, are not going to have implants? Are you serious? You're at Yale and you have access to the best plastic surgeons, the surgeons who write textbooks and are the trendsetters and they develop new techniques. You have access to the best of the best. And he said, I don't. we don't want problems. And I said, what do you mean we don't want problems? And then he talked about, guess what? In 1992, they were banned. And remember, at that time, they were very well, at that time, this was off limits, meaning in 2007, they were reintroduced. So from that day onward, and I'm doing mastectomies and I'm doing patients, seeing patients who had these implants inserted in the 80s and, the 70s. And they're coming back and with the sign symptoms, oh, my chest hurts, the breast implant illness type symptoms, capsular contracture, literally removing petrified rocks from within the chest. And you can imagine the pictures that we have seen on YouTube. And patient did my burn fellowship, and it was a wonderful teaching experience for me. And then I did my plastics trainings, and I went on and I studied, and every single time a patient would come, and they would, as you see, I got brain fatigue, fog and arthritic problems, joint problems, vision changes. And then we see these big studies that come out that say, scleroderma, there are Sjogren's disease, stillbirths, for example, the big MD Anderson. And, over the years, we saw all of this. And I said, you know what? With my training, with my plastic surgery has 3,000 operations, I can do the other operations happily because 5 reasons, 6 reasons. Let's say someone gets their implants. You just said it, and we all know the implants are never supposed to be there forever. If you get it in your 20s, it doesn't mean you're going to be there in your 80s. Average American woman lives up to 82 years of age. If someone in their 22 were to get a silicone implant, theoretically, if they were to live to 82, 6 times she would have had to change it in her lifetime. Number one. So that alone is so I said, I did the math in my mind and I said, trust me, I would love to put in implants and be out of here at 2 o'clock and play golf today, so don't get me wrong. But I said, you know what, let's look at the hard facts. So if this 22-year-old lady were to get implants, it would have been changed technically 6 times. Let's say half every 20 years, 3 times. Number two, she cannot get a good exam monthly to look for breast cancer because that's the most common way that the women pick up on the breast cancer, because now you have an implant that's sitting there, it's obscuring, and an exam is not going to be a good exam because of that mass effect. Number three, the women are not able to get mammograms because it's pushing hard. They're not getting the right respective views. And the mammograms are also another big reason, number two, I would say, where a lot of cancer is being picked up across the nation, right? And more according to the American Cancer Society, it's still what I would say every woman above 40 getting mammograms, making sure, because these are the calcifications. How many women have I noticed who got a mammogram? They saw calcifications. My friend from medical school, his mom ended up getting a mammogram in June. Small microcalcification. Says she not had a mammogram, guess what? The cancer would not have been picked up. And so the point being that now the cancer is not being picked up. Number four, you have problems such as complications, infection, contracture, pain, you have leakage, you have to get, according to the FDA, MRI every 2 years or so, or 3 years. And now all of a sudden you have this anxiety. Now, sometimes you have some fatty necrosis because of the dissection, or you're not sure, it obscures the good imaging and good exam. And also the other set of problems that come with it, like now potentially lymphoma, or you're fine, and all of a sudden all these sign symptoms of breast implant illness. So I said to myself, why do something, and why I don't want to practice this type of medicine. Now we know a lot of women, who have had implants and who've been very happy, and we know who are very happy. This one lady that came to me after 33 years, I said, this is like you're looking back at the Reagan time when you had these inserted, and that's how long ago you had these, to the point where Dow Corning actually went to her and said, we'll take yours out. And she signed a waiver and she said, I love them so much. I said, why are you coming to me after 33 years? Because you should have lived happily ever after. She's like, no, my top right chest hurts. I cannot sit, I cannot breathe, and I feel there's something wrong. And lo and behold, she had a ruptured implant after 33 years. Now, I will tell you, she probably had it ruptured for many, many years. Now, I say this to you, and this is another fact I will tell you. Not a single lady who has explanted with me or a single lady who was on Facebook said, I regret getting my implants out.
Yeah.
You know how many times we buy a car or a house or we go on a vacation and you vote for someone and you walk out of the voting booth and say, I have a feeling of remorse. What did I do? I made a big mistake. Guess what? Not a single lady was said, I regret taking them out. If anything, they said two things. I wish I had never inserted them in, or I wish I had taken them out sooner. And I'm sure you're echoing the same. And I said, you know, that's convincing proof for me. Why should I do something that I don't believe in? And hence me, myself saying, I'm not going to, because guess what? I had a flourishing practice a week into my practice from hand, plastic surgery, reconstruction, skin cancer, face, and I never put in any implants, and happily, because you know what? I said I'm going to practice what my comfort level is. And to this day, and I say this to all the other docs, you know, one of my very close friends, genuine guy, he goes on missions, takes care of kids, you know, the cleft lip palate. I asked him, why are you putting in implants? And he said, well, the ladies want me too. And I said, well, you don't believe in them, then why are you? And that was a discussion, and that was his comfort level, with all due respect to him. But this is why I do the way I do. And I say, this is a good choice I've made. Yes, you know, I'm working harder. When I use the word harder, it's a lot. I would say 3 times harder to put in to take an implant out than to put it in. It is riskier to take them out.
Oh,
And
yeah.
plus, the amount of time, you know, today I put 3 implants out, you know, 3 sets of implants, so it's 6. That was my whole day. I could have easily done 6 patients, meaning 12 implant insertions, and I will say easily 2/3 of the time.
Yeah.
And this is what my colleagues, my friends are doing. And I say this, and much easier surgery, much less stress on the mind and the hand. And I will tell you, the surgery stresses you out because it is a very involved, it consumes you, and you stress during the case. You know, as you will see, your docs, you know, your doc in Costa Rica, when he comes out, it's like as if, and I say, he just ran a marathon, you know, and that's exactly the sensation we have.
Yeah. Um, okay. So I just lost my question. We covered drains. Oh, you're a microsurgeon. Not every surgeon is a microsurgeon. And I try to stress to women, because if you do not choose the right surgeon, and there's a handful, it's a big handful across the United States that can handle this surgery. And a microsurgeon is so important, and you're a microsurgeon, and I would like you to explain why that is so important with this surgery, because this is a huge surgery, and people do not. I think, you know, you can cram the implant in, but to take it out after it's all got scar tissue and everything, it's a huge surgery. So if you could just explain.
So yes. So what and why is it this surgery is hard? Almost 95% of the implants are below the pectoralis muscle. So you have the breast tissue on the top, the nipple, the breast tissue. Then you have the pectoralis muscle, and underneath the muscle, and this is my chest wall, you have the implant in this space. Now just imagine this has been there for 10 years, 12 years, 6 years. It's
20.
literally so super glued to the pectoralis on the top. And on top of the chest wall, you have that implant sitting there. And guess what? You make a turn here, and this is where you're dissecting from. To remove it off of the chest wall is the most challenging part of the case, because if you go down and puncture into the lung cavity, guess what? There is air that goes into the lung, and the patient mandates a chest tube, which is a surgical emergency, and you have to put a chest tube in, so you suck the air out. You have to go and put it to wall suction so that you can address the pneumothorax. And this is why you have to dissect off of the chest wall very meticulously. Now, many of the surgeons feel very uncomfortable dissecting off of the chest wall, because if they make a mistake or they tear in, and it's a couple millimeters, it's not much, you're in big trouble. The patient is, just sorry about that. The patient is in ICU mode. with the chest tube, and patient needs to be admitted to the hospital amongst the many other problems. And you could potentially cause bleeding into the chest wall amongst the many other things. Now, I say this to you, it's very important for the surgeon to feel comfortable operating around the chest. That's equally important. Now, what do I mean by that? So when I am a board certified general surgeon, which basically means that I can take care of trauma patients, I have taken care of gunshot wounds to the chest, for example, thoracic surgery training as far as lung cancer resections. So you're inside the chest, for example. You are on top of the chest when the many, like literally hundreds and hundreds of mastectomies, lumpectomies, lymph node dissections that have been done. Microsurgery basically means that you are able to operate in that very fine plane and be able to very delicately, very comfortably being able to remove that capsule, because many surgeons feel uncomfortable doing that because of the risks attached to the surgery, like we're discussing. So I say to you, microsurgery basically means what? Using the instruments to repair nerves, very delicate surgery. Now, almost all the microsurgeons, like the one we talked about where you take the fat from onto the chest, they're doing microsurgery all the time. But all plastic surgeons, depending on their training and depending on their level of expertise, how comfortable they do when they do, for example, microsurgery. Now, as myself, for example, I feel very good with hands. Repaired a lot of nerves, median nerve, digital nerves, ulnar nerve, and being able to do it with the microscope and dissection. And so you have that level of sophistication and training. My first patient that I saw in my career was a 11-year-old kid that was using a box cutter and opening up a cardboard box and cut the nerve. Was seen by another surgeon who could not put the nerves together, and the patient needed to be sent to a microsurgeon so that they could put the digital nerve, and it was a smaller on an 11-year-old, so you can imagine. So to answer your question, microsurgery is sophisticated, delicate surgery. Dissection off of the chest wall requires that very nice, soft hands. Training as a general surgeon so that you feel comfortable operating on top of the chest. God forbid a chest tube needs to be put. The chest tube will be inserted by me. And if God forbid, and thank God, knock on wood, no problems so far. But again, you go in, you don't say, well, I feel uncomfortable dissecting on top of the chest wall and I'm not going to sweat it. You have to sweat it. You have to take that risk because you don't want to leave the capsule behind. And that's very important for the plastic surgeon to make that commitment before he proceeds to the operating room, that you're going to remove and go out of your way and do the darn best. Even in the best of the hands, you cannot remove the entire capsule, but you're fixated in removing it because you don't want to leave the disease behind.
Right. Right. So that's when doctors cannot guarantee 100% that they'll get the capsule. It's because it's unsafe that it's on your chest wall and they run a risk of puncturing through. So when doctors say they cannot guarantee 100%, that's exactly why.
Right.
Yeah. Okay.
Right. No, absolutely. No, this is what you mentioned. Now, as important as it is to dissect off of the chest wall very carefully, because remember, I'm on top of rib directly. If you touch, it's like you're touching the rib because you have to remove the fascia. And what you have is the intercostal muscles. That's what you're dissecting off. And literally, if you put your finger on the chest wall, you can feel the heart touching and beating, and it has this rolling type of a sensation that you actually feel, and you literally, without any exaggeration, a couple of millimeters away. And that's why it's very tricky. Now, I will tell you, as tricky as it is, obviously the trickiest part is when you're on top of the chest wall. Equally tricky, if not more, is the pectoralis on top. Because if you hurt that muscle, what's going to end up happening as you try to lift something, the pec is not going to contract, or it's going to be literally indented into, and you will not have that strength layer. So I say the dissection of the pectoralis, I find, which not many people talk about, but I will tell you from my experience, that is also a very tedious, meticulous dissection. and to be able to make that turn up in the axilla area so that you're able to remove the entire capsule at that bend or that turn. That's also very important.
So you can repair the pec muscle?
Yes, so when you tear into the pec muscle now, if you look at a 68-year-old lady who has had an implant underneath the muscle, you will find that the pectoralis is attenuated, it's atrophied, it's not as strong, versus the 26-year-old lady that I took care of. The muscle is very thick and robust, young, healthy muscle, and relatively very, very strong because that lady is working out or she is using her muscles on a daily basis. And as we all get older, I find that it is important to repair the muscle for two reasons. Number one, for physiologic function, so that when you lift a gallon of milk, you're not weak. Number two, you want to repair the muscle for two reasons, because you're going to build, and literally, if it contracts, it adds volume to the chest as well.
Okay. What kind of anesthesia do you use? Like there's people who use nerve block. I think Fang, is she one who uses nerve block possibly? Do you use nerve block, and what kind of anesthesia do you use?
So let me give you an example. Today, there is the local plus sedation. Now, depending on the patient, depending on their history, how they react with anesthesia. Remember, majority of the times, that patient can get this surgery done very safely and effectively under local plus sedation. You don't want to intubate the patient, which is full-blown anesthesia where you basically paralyze the patient, and now the patient is 100%. This is what you do when someone needs to get a colon resection or needs to get a liver resection or they need to do gallbladder removal, because you have added risks of clots in the leg, breathing problems and issues. So all my patients today were breathing on their own. They had no problems with, because they were protecting their own airway. They didn't have to be paralyzed, so they could not have potential clots from forming. And it's not a single patient, as you will see, of the many, many, many that I have done, who has come forward and said, oh, I heard this, or I was up, or they had a problem. Because guess what? I can always take it to the next level or to the next level. So I was doing a case, and the patient had the breast cancer, and I needed to dissect around the muscle, and the patient, I wanted the patient to be paralyzed. She had history of cancer. Now, this is very important. All my patients have SCD boots on their legs to prevent clots. I automatically instructed the anesthesia team member, go ahead and give heparin 5,000 sub-Q. I don't want a clot in her leg. Remember, her age is a risk factor. Number two, any patient who has cancer has a high risk of forming clots. So right off the bat, I said
Oh,
heparin. So I give heparin 5,000 sub-Q to every cancer patient because I don't want her to get a clot. I'd rather deal with a hematoma rather than deal with a pulmonary embolus. Very important. I will tell you, in almost all the dissections, I feel very comfortable. If you remember the last time when you were here, the patient had history of DVT clot, right? And I did her surgery, and she was on the Eliquis. I had her bridge to Lovenox, and I was giving her therapeutic Lovenox because I don't want her to get a clot during my case. And I
mhm.
did her under local plus sedation and in the safest manner possible in conjunction with her cardiologist. So the point being, to answer your question, anesthesia, you always start low. That's very effective. If you ever need to, you can always do the LMA, which is the laryngeal mask airway. You can always intubate the patient, but there is no reason to go always general on every patient. If I find that the patient is uncomfortable, and you can tell having done thousands and thousands of surgeries, I always go the next level up in a heartbeat. And I'm always talking to anesthesia. I'm always looking at the screen, making sure that every number, all the monitor numbers are looking fine.
Okay. Well,
So
do you have,
to answer your question about the nerve block, now the nerve, whenever I start making the incision, I always give the lidocaine plus epinephrine, which so that it lasts very nicely for 4 to 6, 8 hours. Now, when they give a nerve block, it always wears off because the blood supply is there, and eventually, just like every medication, anesthetic, just like when you go to the dentist, the block wears off unless you have a pain pump. And I say in an area that's already inflamed, don't put a pain pump, don't put another foreign body. God forbid that may be a potential seed or nidus for infection. And the way I control my patient's pain is, number one, I always, if they can tolerate, I ask them, tell me from your history, what can you take? And I say, well, Norco, Percocet, and I always give that to them as an insurance. You may not need it, you may not need it. I give them tramadol, very effective, works differently. And if they can tolerate, a leave 12-hour acting, so they have 20, 30, 40% baseline anti-inflammatory coverage. Remember, I'm going to be dissecting off of the chest wall. So I want that inflammation to be addressed. I want the Norco to be there as a backup, as a strong pain medication, and they have tramadol. So between the three medications that work on three different ways, this regimen, I tell the patient, see what works best for you. You don't want to be in 0 out of 10 pain. That means you're over medicating yourself. You don't want to be in 8, and you always want to be on top of the pain rather than catching up with the pain. Do you want to be always 3 or 4? The other thing I always tell the patients is, the same day, just getting up and walking around with help. So the first 24 hours, you always want to have someone be with you, because that's key. You don't want to have them be loopy, get out of bed and break a hip or something. So I say get up if they can, and most of my patients feel comfortable. As you can imagine, after a colonoscopy, the patients are pretty active, but still, after 24 hours, does the anesthetic and everything wear off. I say getting up and walking the next day prevents clots. Have the patients be walking. It also helps them with their deep breathing, because remember, the dissection of the chest wall, people are taking shallow breaths. It helps them with their mentation, recovery, and overall, the walking helps with the endorphins, releases the endorphins from the legs and helps with the pain and that. And most of my patients in 5 to 7 days are driving. They're already done with their Norco 3 to 4, 5 days, depending on how they do, how the dissection was.
Yeah, I took pain meds for the first 3 days and then I stopped only because I can't handle pain meds.
Yes, yes. Almost all of them cause nausea, some GI discomfort. They're
I,
like the sisters of Imodium. So I say they come at a price, but you don't need to be in pain, because you have a cocktail of those three medications that I almost always like to
yeah,
give.
it was nice to have them, but it was nice to get off of them. I see somebody named Kelly Christine, and I don't understand this, but I'm hoping you do. It says, but wouldn't you agree, Dr. Khan, that there has to be some lycra surgery there to get that muscle to adhere back down to the chest wall? Do you,
I'm sorry, I do not understand what to be some lycra surgery.
yeah, lycra surgery. Maybe that's a typo.
Yes, I
Anyway,
believe so. Hopefully she can correct that, and I will be more than happy to answer this.
okay. Yeah, I don't know what she's saying. Well, I do have to applaud you. There's people watching that probably don't know who you are, because this is on my personal page and not the breast implant support page, but you are the only doctor in Michigan who will give us the time of day. I've reached out to other doctors, and you are the only one who gives us the time of day. You will sit here and spend your time with us to help women and help explain this to women. And you've never put implants in, and you've always been anti-implant. So I just want to say thank you, and I applaud you for coming forward. You're one of the first in the entire country, one of the first in the country to even come forward and say that breast implants were making women ill and that it wasn't all in our head. So thank you for that.
No, you're welcome. And I want to say this, I thank my professors, my teachers, the wonderful educational system that I've been to, and the training. You know, one of my patients asked, well, it must be hard for you to swim against the current.
Mm-hmm.
And I said, actually, it's very simple and very easy. And, I will tell you, if I can help someone, and I will say this to you, Tracy, look what you went through. I know you so well. And like you, there are tens of thousands of others,
Oh, I just teared up.
and hundreds and thousands of others. You follow?
Yeah.
And I say this to you, because I look at you in the eye and I look at all my patients who come from far away, like the one patient that came and she left her 3 kids and her family, and it's not easy. See, at the end of the day, what's the goal? To live a long, happy life with as little turbulence as possible.
Yep.
And, just don't listen to me. Don't listen to you. Just listen to all the tens of thousands of ladies who have gone on Facebook and YouTube and who have said, wow, look at my before picture, look at
Yep.
my after, look at my anxiety before, look at my anxiety after, look at my bone joints, and look at my after. And I say, you know what? I'm not going to feed my family. I'm not going to do something that I don't believe in, period. Yes, it is too good to pass, meaning as far as the finances, but you know what? I will tell you, for me, that's not a priority. And as a physician, and I say this as a human, you know, we have to be, it doesn't take much to realize that this is wrong. When I use the word wrong, it's not worth it. Yes, there's tens of thousands of other ladies who have implants and are living happily, and I wish them the super best, and I hope the breast implant illness never touches them, God forbid. But I will tell you, just like you and I have, we discussed a lot of things. There are women who will, unfortunately, like you said, the ticking time bombs, it's right around the corner before it will creep up to them in a very sophisticated way where they will start going, mentating differently, or you hit menopause,
Mm-hmm.
or you're fatigued because you're depressed, or you got arthritis because it's the cold, gloomy, cold morning weather, or
Yeah.
you have Sjogren's because you have dry eyes because it's the heat from and lo and behold, or you got GI upset issues because you probably had something bad to eat, or you had diarrhea. And you know what? It fools the mind, and I will tell you, yes, one person may be wrong, two may be wrong, but not the tens of thousands of
Yeah.
ladies. And I say this to you and to all the ladies. This talk hopefully leads to another doc converting and saying breast implant illness, because if we can get more MDs, primary care physicians, family medicine, rheumatologists, endocrinologists, breast surgeons who certainly recognize the entity, and most importantly, last but not least, the plastic surgeons, and
Mm-hmm.
we get the FDA, Lansing, and all of these, just like with Jewel, to have the president come forward and say, you know what, it's not worth the risk. And that's all what we're saying. And this is what I'm saying. Why should I do something when I have so many other ways of helping? And I don't want to hurt the body. And that's the oath we took. So I
Yeah.
say, and this is my take home message, and this is to my colleagues, my friends, my plastic surgeons, my buddies. I say this, when I drive home, I feel like so relieved and happy that I'm able to change at least one life today. And we can make a difference for the better. And I say this, and this is what I will end with, it's not worth it.
Yeah. This wasn't worth it.
Yeah, yes, yes,
If
yes.
I had known now what I didn't know then, oh my gosh. Yeah.
Mm.
But although I don't know, Dr. Khan, if 33-year-old Tracy would have probably still got the implants with the warning.
Can I say something? And I say this to you, but
That was really
if you,
dumb.
Tracy, I sit back with you and I look at my life, I will come up with a textbook of things. I would look back and say, what was I thinking? What was I doing back when I'm young? I'm
Yeah.
jumping from a building. I want to say this on Facebook, but I'm going 100 miles per hour, with my friends on a nice Mercedes. We all have done that. You know what I'm talking about, and say what was I doing? But you know what? This is
Good
what
thing
makes us.
with me because I was going 120 in a Porsche on 690.
Right, right. But the point is, I'm trying to say is we all learn from our mistakes, and we all make and say, you know what? Why am I here with you? And I made it a point and I say, you know what? I could have gone on. One of my friends has gone on his whole plastic surgery career without putting a single implant. No one even knows that he's a plastic surgeon. He's a hand surgeon and he's plastics trained. But the point here is that we all look and learn from our experiences. We all have made mistakes. We all are human. So we never regret what we did, and we never should. But and this is what I said, this is for the 22, 25-year-old ladies who are interested in implants, do your homework.
Yeah.
Understand what this is, because you want to sign up for something that you know the outcome for and what the 5, 10, 15, 20, 25, 30, year outlook is. If you go in uh, well informed, and this is part of the whole informed consent, then you will be able to make a better decision. And this is also true for the men that are out there
Mm.
who, and I hate to say this, but as a man, I will say this, we inevitably coerce slash force slash psychologically manipulate slash whatever it may be the nice ladies and saying, well, you need to go higher on the implants or you need to get implants. Not worth it, not recommended. They come with a lot of problems, and I say this again, not worth it.
Aw. See, you're a nice guy. You're a nice person. You're a nice human.
Thank you, thank you.
You are. You're one of the good ones. I'm glad we have you here in the state of Michigan too.
Mm.
We're very lucky to have you, Dr. Khan.
All right.
So we'll end this. Dr. Khan's in Novi, Michigan. If anybody needs their breast implants removed or you need any other surgeries, he's an excellent hand surgeon. But anyway, and we'll get this reposted on our pages. But if anybody needs a good surgeon, I think you are probably our best surgeon that we have in Michigan.
Sure.
I
What
think
I
you're
will
the best in the country, but I think
yes.
you're
See,
the best.
what I propose is, we have very nice, powerful, strong people who are discussing this. I suggest that, Dr. Feng, Dr. Chan, the explant specialists who do it right, teach and educate, get together, had a forum, and so that, because that way we can better educate the medical community and recognizes as an entity, because there's now, this is not like in the early 2000s. This is something that is very true. We need to study, we need to better define, we need to have the manufacturers, the biochemists, the chemical engineers, the biomedical engineers, all of us focusing on and looking at and studying this so that we can help. We have a lot of technology. We have identified the human genome, we have so many advances in medicine. We can certainly do a lot of learning and educating, and so that we can diagnose this better and we can pinpoint and say, what, we can treat this illness in patients who start getting these sign symptoms, and hopefully we get a blood test, we get an exam, we get some assessment objective, so that we can reproduce it and offer the patients the best of the health.
All right. Well, thank you, Dr. Khan. Thank
You're
you for all
welcome.
your time. You always give us your time too. And for the record, for
Yes.
the record, it's been suggested that like I have some bias towards you. I didn't use a doctor in Michigan. I explanted a year and a half ago down in Costa Rica. I have no ties to Dr. Khan, nothing to gain. I'm just trying to find women doctors here in Michigan. So
Okay.
I have,
I'm
for the record, there's nothing.
going to I suggest this to the patients. You know, there you need to go out, seek consultations from multiple docs. Find out, remember at the beginning, how big is the incision? How much time do you take? Do you give implants back? Do you take pictures? Are you a believer in breast implant illness? I want you to ask the respective questions. If your doc is doing a lift and also an explant in 3 hours, that's automatically out. If your doc is doing a 3 centimeter incision to do an end block, out. Your doc is not putting an implant, out. Now I will tell you, thank God I have, from my practice overall, what I want to do is this: teach, help, because that way someone doesn't have to fly out. Someone in This lady had access to the the very first lady who had the implant rupture on the right, and on the left, the implant that was purposefully and deliberately punctured with a needle so that it would match the one on the right by a board certified plastic surgeon out of La Jolla, California, from what I understand, a major enterprise, a major higher concentration of plastic surgeons. So we don't get these 101 mistakes. so that we better understand and better define, because that way we can establish a consensus about how and what is the best way to deal with it. Because to
Yeah.
them they think they think they're doing it right for the patient, which is wrong.
Mhm. Can I ask you one more question before I let you go?
Yes, please.
Okay. So I had the textured implants for 12 years, the first 12 years, and then I had a rupture. So I woke up and they were saline. So this side was flat and this side wasn't. So I knew I had a rupture. I don't know how the heck I got a rupture when you've got that thick capsule around it. My guess is from mammograms. What do you what do you think of mammograms when you have implants in? Because I think that's what's causing a lot of the ruptures.
So there are now mammograms are an important tool that picks up on the breast cancer. Now, guess what? There are modified views of mammograms, Auckland views that you can get where the pressure on the implant is minimal.
Okay.
So you can get these modified views at these major centers done right so that you don't put pressure on the implant.
But how do you think we're getting all these ruptures? Because now, like after you one time showed me an actual capsule and let me feel somebody's capsule that you had removed, I I sat there and wondered how did I, with no impact to the chest, get a rupture out of the blue, like through that thick capsule? How did that happen?
So number one, pressure. Number two, as you move. Now, I will tell you that one patient that came to me from the Pacific Coast this morning, the very first case that I did, I asked her what caused yours to rupture. You know what she told me? She was on the computer typing, and all of a sudden, it's deflated. She was on the computer, and I said that's usually how they were doing a very non-traumatic, simple, passive activity, just like typing. And it's because I asked her what is it and why is it that you need this removed, and what sometimes a lady was riding her bicycle and another person crashed. That was trauma, and obviously you can tell that was a mechanical disruption. But in this case, she was typing, and I will tell you, it happens. I do not know. There's pressure from the capsule itself that may put, just as you will see, the very last case had grade 4 capsular contracture. The capsule itself pressed the saline implant where it caused it to rupture.
Huh.
That's certainly possible. That's certainly possible. Like putting a seatbelt on, for example, or putting in trauma after some time. If you can imagine a saline bag, the IV bag, obviously, if you can
Mhm.
imagine, that's a silicone saline implant. After some repetitive trauma, something will give, because just like, and remember, after some time, guess what? They're not supposed to be there forever. And there is a break, there is a small break, and then all of a sudden a rupture because they're not meant to be there forever. So everything breaks down with time. And so that's basically what ended up happening. Now, it's very uncommon to get a saline implant rupture 2 years into their augmentation. But after 20 years, you can imagine the wall of that silicon, the wall of that saline implant likely had denatured, which all happens. And that's why maybe that weakest link was where it ended up breaking at one of the seams. I do not know.
Yeah. Okay. Well, all right. Well, this has been wonderful. Thank you.
What I will do, Tracy, is we can certainly meet again, i.e., we can get some questions, the list, and
Okay.
see what you think are good questions. And we can certainly do this at another time that's good for all of us.
Okay.
All
All
right.
right. Well, I appreciate you very much.
You're welcome. Take care. Bye-bye to everyone. Hopefully
You,
you found this informative.
oh, I did. I'm sure they did. Thank you, Dr. Khan.
You're welcome. Bye-bye.